Hello, everybody, and welcome back to TARTLEcast. You are joined by one of our original guests here, Dr. Christine Cassel. She is a, probably I'd say, longtime friend of mine and a local resident here in Santa Fe, New Mexico. And recently, Chris, you have published an article in the New England Journal of Medicine with one of your research partners here, physician Ida Sim.
Yes.
Is that correct?
Yes.
Fantastic. So I got a chance to go through this, got a little perspective. And I'd like to have you also walk me through and explain some things about this article itself or in the journal, and also the impetus for why you had written it and why you think it's important right now at this time. Is that fair?
That's totally fair, Alex. And I really appreciate having a chance to talk with you about this.
Yeah, because there's nothing better than doing your work, but then also to get to be a little evangelical about it.
Right.
Right? Now, with papers are static.
Right.
So now you actually get to expand upon the ideas which you've codified here, right, with your journal partner, and really take this to the next level. So for the audience that's listening, I was wondering if you could start by giving a little bit of background to yourself. I know this is important in the medical industry and people that do research, that they understand your background or the people that have participated in the creation of this article.
Okay. So I'm a physician. My clinical specialty is geriatric medicine.
Sure.
I was one of the early physicians who got serious about ethics as a scholarly discipline in medicine. And throughout my career, I've done research. I came to medicine with a background in philosophy, so
Sure.
I brought that to it. And so the field of bioethics really has evolved over the last 30 years, which is really sort of the span of my career in medicine. And so that's important background.
So, and before you jump, some people are not totally knowledgeable on what bioethics means.
Right.
So could you just give a little bit of a definition for them so they have more context in your work?
Sure. The ethics is the philosophy of moral decisions. And what are the decisions? Not technical, not what does the evidence show, but what is the right thing to do? And in medicine, that has a lot of power because we're dealing often with life and death decisions.
Sure.
Often think it's not clear. There's real conflicts between values, deeply held values. I'll give you an example. You want to respect a patient. A patient comes in, maybe they're a little confused or delirious, and they're saying, "I just want to die." But your responsibility is to save life and to heal the sick. And so you have to decide, am I going to respect what that person says, which is one of the fundamental principles of bioethics?
Wow.
Or am I going to do my other fundamental principle, which is to respect life and try to save that person's life because I know that they're not thinking clearly?
I can see how
That's one example.
Sounds like a rock in a hard place.
Exactly.
And if you do that day in and day out, that's a tough job.
Between a rock and a hard place is one way of describing what I call an ethical dilemma. So, and so there's been a whole field of people working in myself in medicine, but I have a background in philosophy, but also philosophers, lawyers, social scientists, other kinds of disciplines that come to bear on some of these really more complex problems, some of which really happen at the bedside level where you're making that decision.
Sure.
And some of which, a lot of what I'm talking about in the article, happen at the policy level where you have similar rock and hard place dilemmas.
Absolutely. And policy is always a tough line because how do you manage ethics for large crowds of people? Are you the determinant person to say that this is the appropriate ethical standard for everybody?
And particularly in a society and a country like ours, which is so diverse and people with many different religious backgrounds, many different cultural backgrounds.
Sure.
So that's part of the challenge.
Oh, I can absolutely see that. And so can you give a little bit of background on Ida Sim?
Ida is a brilliant physician with a PhD in computer science who
Fantastic.
is at the University of California, San Francisco, where I'm on the faculty.
So that's how you two got connected.
She is a real leader at UCSF and actually also working with the University of California, Berkeley to develop healthcare computational science training, PhD level training, and also policies for how the university deals with issues of data privacy and new technologies like AI.
Sure.
So,
It's what I think is fantastic. You sit with this philosophical background,
yes.
and you are meeting also other researchers who have very tech-focused backgrounds.
Right.
And I think what has been missed for a long time, actually I know what has been missed, is what I would say the insemination of philosophy or understandings of moral and ethics into the design of technology.
Right.
We haven't done that hopefully across the board in most industries. And healthcare being one when you're dealing with human life, that's been a miss for a lot of the tech that we've put together.
Right.
And I really think it's an important time where that bridge is occurring. And it's great to hear that UCSF and Berkeley are both taking the steps forward to say we need to impart more of this philosophical, spiritual, moral, ethical, implications and standards into the tech itself, because we know how quickly it's developing.
Right. And that's really what prompted us to write this article. Importantly, there have been lots and lots of articles in the medical literature and in the blogosphere and, coming out of OpenAI and other kinds of developments, talking about the ethical issues in AI. So that isn't a secret that those problems exist. But what was important about this article is it's part of a series. The New England Journal is the leading medical journal in the country, in the world, and they initiated a series to revisit basic issues in bioethics over the course of a couple of years. And they invited us to do one on AI. So this is part of a series that's focused not so much on the technology, but more on the ethics.
Do you know what I think is important about that? This reminds me of pre-Socratic philosophers. Their whole idea was to focus on first principles thinking.
Exactly.
Now, so many people develop. There's a layering process that happens in life and the evolution of consciousness. Yeah. And so when I hear things like this, they're said, wait a minute, let's take a step back and look at the fundamentals here. Right. We've gone so far in one direction, but are some of the fundamentals amiss?
Right.
And I love that they're taking another look at it, and you, with IDA, are literally at the head of the spear.
Well, and, what we point out in the article is just what you said, the importance of principles, remembering what the principles are. Some people have said we need a whole new way of thinking about bioethics.
Really?
Yeah. And we gave that some serious thought as we considered this. And I thought, no, actually the fundamental principles that date from the Belmont Report, which was published in 1979, that was instigated by some really terrible research atrocities that occurred.
Like what? Tell me. Give me some history.
Like the Tuskegee syphilis study.
Really?
Very famous one where black men who had acquired syphilis were followed to study the normal course of the disease, even years, decades after it was known that penicillin would cure the disease.
So you're telling me, with clear knowledge and available medicine for the curing, these people continue to study these human beings
and it's
longitudinally without even ever offering anything.
And without ever even telling them.
Yeah, that's a travesty.
And there were lots of examples of that. And the reasons in the 60s and 70s, it's hard to put yourself back there, but people were so excited about the advances in science that happened then, that seemed to be the overriding value when we talk about conflicting values. And of course, there was racism and all kinds of other things at play. But there were lots of other examples. There was an example at the Willowbrook Institution, which was an institution for developmentally disabled children, where they followed kids who got hepatitis because it was endemic, it was catching. And didn't tell their parents, didn't inform anybody about it, but out of that developed eventually a hepatitis vaccine. So they thought, that's what they were aiming at. They weren't thinking about who are these human beings.
That seems like an excuse.
Well, it was a different way of thinking.
It sure was.
It was wrong.
Yeah.
No doubt about it. So the National Academy and the U.S. government put together a national commission on research protection of research subjects that came out with this Belmont Report.
Okay.
That stipulated the 3 principles of respect, beneficence, and justice. Those are the 3 principles. And out of that came all kinds of regulations that now people take for granted in medicine. It was originally designed for research, but actually is applied in clinical care too. So I'll give you an example. The beneficence is basically what we think of as do no harm.
Sure.
The physician is responsible for doing the best thing for that patient. So that's number one. And then that has to do with making sure that you know the current science, that you're really offering the patient the best thing that you can. The second one is respect for persons, which sometimes is translated into autonomy. And that has to do with what we were talking about earlier, the fact that people come to you from many different cultures, many different value systems. And your job is to respect their values, not your own.
That's correct, because you don't want to impart them upon them because that would be unethical.
Right.
Right? They haven't grown like that. Their culture is not like that. Their practices are completely different.
Now, they may be making decisions that you don't think are right. I mean, I'll give you a good current example is vaccine deniers.
Sure.
So they come to you with these firmly held beliefs. And, it's not wrong for you to try to convince them, but it would be wrong for you to tie them down and give them a vaccine just because you know it's better.
Yeah, absolutely.
So that's respect for persons. Now, in the research world, and actually in much of the clinical world, the way that's implemented, part of the title of this article is implementation, because it's not just the principles, like how do you actually make this real? So in the research world, it's informed consent. It's required by law and regulation and ethics to make sure that a patient, before they enter any research study, they know the risks, they know the potential benefits, and they know that any conflict of interest that you, the researcher, might have, and they know how they can change their mind if they want to. So that's informed consent, and that's very well established. It works very well.
So now there's a bridge.
So how do you apply that?
Correct.
In the world of large language models and, generative intelligence, where it's just not feasible to have every single person whose data is involved in these training sets to give. It's
very difficult.
It doesn't work that way. So how then do you implement the principle of respect for persons?
Sure.
In this setting. So in all of these areas, it takes a rethinking about how to actually practically implement it. We don't need new principles. The principles are perfectly good, but it's not clear. We need some really smart people and some creative thinking that includes technology experts as well as ethics experts and legal experts to figure out how do we actually create workable implementation of these ethical principles.
And that makes sense. And that's where it leads to the title, The Ethics of Relational AI, Expanding and Implementing the Belmont Principles.
Right.
So in 1979, you discussed the basic ethical principles, right? Beneficence, respect for persons, and justice. Now, of these 3 things, right, which essentially were the dawn before the, what I would say, the AI revolution that's currently happening, specifically in the healthcare space, how does this generate sort of what you would call a new ethical calculus when it comes to establishing ratings within the AI itself? So if I were to go to a large language model and for whatever data it's collecting or sort of the return output that is given from some predictive ability, how do I determine that the way it has been built and what is being given or what information is taken in, how does that account for like this ethical calculus Is there a rating measure that you're looking at to say, okay, if I have a choice of 16 different AI models, right, or machine learning models, how do we determine, one may be more efficient, one may have a better payer output, one may have a better patient output, or, but all of them may be lacking in two of the three categories within our ethical calculus. How are you looking at that quantitatively?
Well, right now there is no such rating system.
So you need to make
exactly
one.
That's what we're calling for here, to have some kind of a system, and there are different ways to think about how that could actually work. But there needs to be, this is moving so quickly. In the old days, in the days of the Belmont Report, once the country woke up to the need for this, they put together this group. The group worked together for 2 years. They came out with this big report, and then it was implemented. That's never going to work in the AI space. It's moving too quickly. So first thing is you need to have real-time ethical oversight. So how do you actually do that? So the reports come out not every 2 years, but every month.
I like that.
Like what's new, what's happening. And they actually can use AI to monitor AI.
Absolutely, they could,
And some people have proposed that there be a network of smaller accountability groups, frameworks that would be hosted by maybe healthcare organizations, maybe big tech companies, maybe governments.
Do you think it should be?
I think it should actually be all of them around the table.
Otherwise, you'd have, first of all, you don't want bias in a model, right?
Right.
So then you don't want bias in the group, which is judging the models.
Exactly.
Right?
Exactly.
Or as best as you can manage it because you can't remove it.
Maybe you even have some Uber oversight group that, comes from different parts of the country or from different perspectives that kind of monitors what's going on with these distributed models.
Sure.
But whatever it is, it doesn't exist yet. And, the United States Congress is not likely to take this up real soon. They do talk about it periodically, but they don't move quickly, and they're very dysfunctional in lots of other ways that we know. And so it's going to need to come from the private sector, I think. But with government input, there's really good people, and a number of the articles that are coming out are including people from the Office of Technology and Science and Technology from the White House.
Sure.
And all of the different government agencies that are National Institute for Standards and Technology, for example, the FDA is interested in this. So you could get them, but they alone can't do it.
No, it needs to be a collective.
A collective. And so there is one out there called the Center for Health AI that was started by MITRE, but that includes all these different players. CHAI is the acronym. And we mentioned that in the paper. And there are others as well. So I just think it's urgent that there be some attempt to put these kinds of things in place so that people like yourself that could answer the question, how do I know which models?
Correct.
Do I have to figure this out myself? Does every developer need to have an ethicist on their staff?
Probably.
And would that even work? Because, people come with different perspectives, and you want to have something that is pretty consistent across the industry. But that doesn't, to Sam Altman's point, he keeps calling for regulation. Even within the last couple of days in the Washington Post had an article arguing that we need something like the National Transportation Safety Board or the International Atomic Energy Agency.
Sure.
Or even, he used the example of UCAN that distributes internet URLs.
That's right.
But that's a very stable kind of thing. I mean, I think may not be the best model. You need something more.
When you get into healthcare, sometimes the lines aren't as black and white.
Yeah.
Right?
Yeah.
I know internet identifier pretty easy. You got this domain name, here's your, you get those, whatever.
Right.
Now, the way I've seen this is, and I've also read some of the research out of the Santa Fe Institute on the effects of evolution, right, and choice. Pretty cool stuff. And, David Krakauer is producing a series of all the works out of the Santa Fe Institute. But one of the elements I'm looking at here are almost like the evolution of ethics naturally. So now, if we talk about a framework for us, essentially the railguards,
Right.
you and I know that algorithms can have drift.
Right.
All right. The second you turn these things on, they
Yes.
train themselves in
They
certain
do.
directions.
We know that. Yeah.
All right. Now, to me, the lanes in your bowling alley, right? You know, those bumpers that come out,
Right.
those aren't in place.
No,
You're-
that's totally right.
So
That's totally right.
the way I would say, like, as a good starting point, and this is my opinion, right? Because I deal a lot in data ethics.
Yeah.
Let's look at how ethics have evolved naturally within nature. In a simple instance, mothers protect their offspring. They provide them shelter, XYZ. We can look at these very basic things that are shared across species. Now, we could apply that outside of any bias, because we're talking about evolution, something that applies to all of us here.
Right.
And we could start with that as a normative framework for all the people that are developing AI to push it in a more ethical direction before a bias of ethics can come into place to say, oh, this is more ethical. Well, let's look at the thing that's a basic parameter for all, right? And that's just taking a strictly scientific format before me bringing in a spiritual one.
Mm-hmm.
You follow me on that?
Yeah.
Because this drift can do damage. So can you give a little bit of an example about what this drift does in the algorithms itself?
Well, that's been well shown in. There was one algorithm that was with a large healthcare system in the Northeast.
Sure.
That was predicting sepsis, which is a potentially life-threatening condition, that patients in the hospital who get infection and then the infection becomes widespread throughout the body and they can go into shock and die within 24 hours very quickly.
No, thank you.
And it's very hard to know which patients are going to be vulnerable to that. And if you could even get like 24 hours sort of predictive analytics of who are the patients at risk, then you can watch them, you can put them in the intensive care unit and prevent more people from dying of this disease. So that's been a real good algorithm for old AI, not generative. I mean, just predictive AI. And but in this algorithm, over time, it drifted from being 80% correct to being 50%, which is a coin toss.
Yeah, I might as well just be in there with my quarter.
So, right. Because, and the reason that they think it happened is because over that time, the health system acquired additional new hospitals and groups, and so the baseline population changed.
Correct.
And so that's one explanation for drift. Another explanation for drift is one that we mentioned in the paper, is that the clinical reality changes. So early in COVID, a lot of people lost their sense of smell.
Correct.
Anosmia. That was a signal. And now it's much less common in the current COVID variants.
So you can't train on that to say,
so if you use that old data, then, you need to continue to have new data. So, so there's all kinds of ways in which, and that's the number one principle, beneficence, which means you have to get it right.
Yeah.
And so that how do we rate or manage models or AI systems in the generative world that we can say this is more likely to be right than that?
Sure. Now, when you talk about the right beneficence, now patients, doctors, and other hospital staff are all a part of the aspects of the recording of the health state of some person that comes into a hospital.
Right.
Now, it is, in most instances, somewhat difficult to get your hands on that information to train models because it has a lot of PII in it.
Yes.
Now, some companies come out and say, hey, we scrub PII, blah, 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 we're protecting privacy. I know that's a crock, right? Is frankly not true because...
Well, not only that, but if you don't have that data, then you don't have an accurate set.
This is exactly correct. So one of the major unlocks we have done in the healthcare industry, just at TARTLE, is that we have carried over the ability for people to share with full consent that PII data directly back to the plans themselves or further to research facilities. So rather, in this old model world that we're looking at here, most of the people say, I need to go to the research centers or I need to go to the hospitals themselves or the hospital systems and request the anonymized data. Now, that means you have to go to all these individual silos.
Right.
Now, the unlock here is we took the principles, let's put the patient at the center of this, and the patient can unlock that value across multiple different areas.
Not only that, but what TARTLE has done is the health systems are not allowed to share that personal information.
Right.
But the patient can give you consent to do that if they trust you.
That's right.
And so you've actually found a way to use that old-fashioned concept of consent.
Yes.
But to do it electronically and in a much more efficient way.
Correct. And I know in your article here, there was questions about the beneficence, right? And the almost a lot of the benefit that gets back to not only the physicians themselves, but the patients too. So now, not only is it a consent thing, say when I'm being monitored in a hospital by some sort of AI system, but also if I'm the one participating in sharing my data that is training said model,
right,
I should be able to receive some sort of royalty or compensation for doing so.
Right.
And how awesome would that be that the healthcare system could pay back to those individuals using a technology like TARTLE to then help them offset the medical costs that they're bound to get? Go ahead.
So that goes straight to the third principle, which is
I was
justice.
teeing you up. Yep.
Right. Now, a lot of the other organizations that have put out principles, one of them is called fairness, I mean, which really is the same as justice in a way. But that's only fair. And that's something that our world of big data in every aspect of our life has ignored, that all of these huge companies get your data because they give you something ostensibly for free.
Sure.
But then they have your data and they make huge massive commercial gains out of that. And the person whose data is used never gets anything back.
Correct.
So that's really a wonderful way to think about justice, or one aspect of justice.
Sure.
I mean,
the starting point.
Justice is a complex. The other thing we need to talk about is the bias in the data sets.
Absolutely.
And ways of overcoming that, which this potentially could do. A lot of organizations, increasingly now, there's a trend in the beginning of generative AI, which is, less than 2 years ago, but already it seems like a long time. There were discussions between healthcare systems and big data companies.
Yes.
And because they needed the data to train on. And lots of concerns about the ethical guardrails and how to manage that. Increasingly now, the healthcare systems are wanting to keep their own data.
Correct.
And create their own training models.
That's right.
For their own. So I understand from a legal and regulatory standpoint, or maybe even ethical, why that's happening. But anytime you reduce the size of a data set, you get less accuracy.
That's correct.
And I mean, you know this better than I. And so I'm a little worried that this tendency is going to give us more bias. I mean, it may work for your healthcare system if it totally represents your patients.
Correct.
But, there's always the outliers in these systems.
And many of these people migrate through systems. They change jobs, whatever it might be. They're going across different states. Plans aren't the same. So then it doesn't help anybody when there's such a flux with your base model of information.
And you're going to end up with different information, for a health system in Mississippi compared to a health system in Seattle.
You're absolutely correct. And frankly, they're two different cultures.
Yeah.
So thank you for explaining that. You and I could go down a rabbit hole on that all day. Right. And that dealt a lot with the efficiency gains, which you guys had brought up here in the article astutely. It's like, will they be distributed fairly? And that's a tough thing, because then you're also saying, if I'm the person with the model and I'm gaining from this, they're the ones that determine the value back to the people. Right. It's very difficult. And so, technologies like TARTLE, you invert things like that, and you get it, and it's developing over time. Now, the next element here that you had also talked about is moral injury. This is something I wanted to hear a little bit more about, because it wasn't fully broken out. It's just me, because that's what I want, right? But this article wasn't written for me. I want to hear more about the burnout owing to this increased moral injury. Could you talk about that?
The moral injury is a term that comes from the war experience, that people who've been in war and had to kill other people or been in really terrible situations
Sure.
come back with a sense of moral injury, that I did something wrong, even though they know why they were doing it.
It still feels wrong.
It feels wrong.
Yeah.
And that's particularly people with, I forget the name of the movie about the sniper, the Hurt Locker, I think it was. That.
Oh, yeah. Great film.
That how agonizing this is. Well, that term has now begun to be applied in healthcare. It came vividly to light during the peak of the COVID epidemic, when we didn't know how to treat this disease.
Sure. When
people were, instead of in an intensive care unit, you may have a patient die once or twice a week, maybe. Mm-hmm. You were having 10, 12 patients a day
that's a lot.
Die. And just for a physician or a nurse or anyone involved in patient care, it's agonizing to watch and to feel like you can't do anything, and you don't know what to do. And then you don't have the equipment or the personal protective equipment
right.
And so there was a kind of a feeling, and that's this idea of moral injury, and leading to burnout in the health professions. Now, some more subtle ways that can happen is by, and I want to get to this in the AI context, is in the context of a clinician working for a big health system.
Okay.
Where the health system is putting, or the insurance company is putting the bottom line before what you think is right for the patient.
So you're saying in the model with its output,
and
one of the priorities would say the economic benefit.
Right. But even before AI, that you have prior authorization. So the insurance company doesn't agree to pay for what you really think that patient needs.
Sure.
And what are you going to do? That's a little bit of moral injury every day as you get sort of beaten down by the system that prevents you from really doing what you think is right.
So
in the AI context, and one of the things I think has not been really had enough attention paid to it is whose AI is it? So we have all kinds of wonderful ways that the new AI can help doctors and nurses get out of the paperwork and the bureaucracy of medicine. It can, in a very short period of time, go through a long, complex chart on the EHR. The EHRs are not so easy to navigate.
No, they are not.
But you can tell ChatGPT or some version of that, give me a 3-paragraph summary of this patient's history.
Correct.
Or you could even say, write me a letter to the insurance company asking them to pay for this treatment, which before the doctor had to do. So there's all kinds of ways that would be wonderful for reducing the sort of computer work that the doctors and nurses have to do. But the systems that are brought in by any given hospital or health systems to do that could have different values baked into them. So is it a system that is primarily focused on efficiency, which means at the margin, you don't prescribe treatments that are only marginally effective?
Yeah.
Well, you, the doctor, this patient may say, I want that treatment because you're respecting that patient's values.
But the output says, we're not going to do that because it's only a marginal change
over this many statistics, and it doesn't. So that's why we say the clinician, and here I'm including nurses too. The doctors and nurses need respect and beneficence and justice every single bit as much as the patients, and that's a new concept. It always was that we were the ones with the power.
Sure.
And we owed it in a fiduciary way to the patient to have these responsibilities. But now there's a third person in the room.
Yeah.
The third person is the AI. And they aren't morally neutral, these AIs. So that needs to be more visible to the clinicians, The clinicians need to be able to trust the information that's coming from the AI and not have to double guess it. Here's another big challenge that has been written about, which is that some people say, well, that means that some physician or nurse needs to review all the outputs of the AI. Well, that's just not feasible.
No, it's not.
And early AI, one of the big benefits was it's very good at diagnosing images.
For sure.
Mammography, a little
retinal scans,
abnormality, retinal scans, chest x-rays. And one of the reasons for that is that AI doesn't get tired and human beings do.
They do. So
even
we
the
miss that.
best radiologist can occasionally miss something, but the AI will not miss it. Well, so you're going to ask the human brain to oversee this AI and find one little tiny error or one little tiny drift.
It's unreasonable.
It's unreasonable.
And, there's an old quote. I translate very old German texts. And there's an old quote that I've always really enjoyed. It's called, "What is right is reasonable, and what is reasonable is right." And I think, one, there's a nice balance to it. But two, it does say a lot.
German.
It does sound very German, doesn't it? Now, with the elements of this and those pressures, they're almost before somebody goes into an appointment, okay? They should have the choice to whether they want a normalized output to be given to them with the doctor's recommendation.
Right.
So now there's an interesting training element to say, okay, you are seeing this one clinician. Now there are a series of other people all over the United States or all over the world, depending on the data set, that are coming in for the same disorder or disease. We can offer you something that we would say is probably 80% accurate, but may differ from what your clinician says, but we will give you both things. That should probably be an element of choice given to the patients when they come in. It should also be another element of the clinicians themselves to choose whether or not they give that as an offering.
Mm-hmm.
Because now you're saying, I've gone to Harvard Medical School for X amount of years. You don't want my opinion, but you'll take the one that gave you a quick 3-paragraph summary, right, on the medical history.
Right.
Now, for this, you have, those biases in place, but it also takes, there's a drag that occurs against the professional backgrounds and also the weight in what someone is diagnosing with.
Right.
Now, say, for instance, I'm just going to come up with a hypothetical scenario. Someone comes in and says, "Hey, Alexander, I'm diagnosing you with early stage Alzheimer's." Okay? Because of X, Y, and Z. I, as a clinician with my own eyeballs, have seen this before. I've seen these patterns. Humans are good at pattern recognition. Fantastic. Okay. Thank you, doc. I would also like the opinion of a system that has curated information from 3,000 other doctors and other patients with early onset Alzheimer's. This is telling me the opposite. Now, what sort of dilemma happens with the relationship between the provider and the actual patient at that point? Because like you said, we've brought in this third party into the room. And many people put a lot more faith into technology than they do into doctors.
And there's another aspect of that, which, potentially is very positive that we're already seeing, which is that many people are getting their health information from generative AI.
Yes.
And that could be a great benefit in things like mental health and other where people don't have access, or they may not have great insurance, or they live somewhere where there isn't a physician nearby,
right,
in a rural area. So that could be a very positive thing, that people can solve a lot of their own medical problems.
Oh, for sure.
But they also ideally would have the option of going to a physician or a nurse practitioner or provider and talking it through. And this is where the relational part comes.
Yeah.
Because I think we need to train medical students and ourselves, anyone involved in patient care, to actually welcome that conversation.
Yeah.
Say, okay, let's talk through what are, yes, I may have gone to a great medical school, I've had all this training, but I'm only one human being with one brain.
Yeah.
And here's a brain that has
a collective
that, has much more information, and I can learn from that too. But I can also give you my personal perspective, which for many patients is a very valuable one. So ideally, we're going to have that third person in the room, and it's going to help us with it. But ultimately, it's going to come back to a conversation between the doctor and the patient, where the patient has the luxury to be able to see a doctor. And so I'm also seeing the potential for so many situations where patients don't have that luxury. And they might be able to actually get more, at least solve some basic problems or get basic information.
Sure. Especially around analysis of things like social determinants of health data.
Right.
Hey, we've analyzed some basic stuff. We know mortality rates. I mean, you wouldn't be spewing this back to people, but based on what you've shared, we would recommend changing these lifestyle habits.
Yeah,
simple.
Exactly. You know, or you know, I have a cough and a fever. Do I need to go to the doctor or not? Well, the AI can ask you a few more leading questions that would be the same thing
a doctor
any
would ask.
Primary care provider would ask, and it may turn out, no, wait a couple of days, see if it gets better. If this and that happens, then yes, you should go to the emergency room. So, you know, that can reassure people. It can give a lot of good advice.
Yeah, I like that. And with the patients and the doctors together, I know that currently today I can go in and record my doctor's appointment because I can't keep handwritten notes. But as long as I ask the doc, I'm going to record everything that's being said. Plus, the doctors are doing a public service.
Right.
Now, one of the dire needs of the major AI firms out there, especially in the medical space, is to actually capture the conversation between doctor and patient in the hospital room. Now, the only technology in the world that allows that to occur is our technology, TARTLE. And so patients can go in and share their recordings, whether it be audio or audio and video, and they can give that back to the model training sets and say, here is the outcome inside of a very private event, but totally consented to by all the parties, sharing this information. It's fantastic, rich information that's very helpful. And they also get the beneficence of this, the benefit and the justice that occurs. There's balance in that system through that. Now, the way I see that evolving is that as the computational power is increasing for these AI training sets, okay, when I come in as a person with a very specific cultural background and preferences, or even specific religious tolerances, like don't say, like, this is what's going to happen, I can't do anything outside of this framework. I see that in the future, the systems will know that when I enter the hospital. Why? Because I have shared that data over time with my rich personal context. Now, me as a human being are pre-establishing guardrails so that when I get an output from the AI, it knows my personal guardrails and will not share anything beyond that. No other recommendation. And I think what happens here is that you have now nuanced ethical calculations that happen per patient rather than deciding for everybody. But the interim in the beginning for us will say, let's look at the baseline ethical calculus, which has been missed, hopefully, which you bring up. And I'm saying phase 2 goes beyond that to say, okay, now that we have a baseline for everybody and we've built up our training sets and we've sourced it ethically from people, blah, blah, blah. Now we can also focus on, let's put the guardrails up for each individual patient, depending on their needs.
You know, the same way that Amazon knows what you want to buy before you do. Right? So absolutely. And this could be very personalized. It could get to that respect for persons with the assistance of AI.
Yes. Now, one of the major things you had here in the article, and I think we need to talk about it again, was your call to action. Okay?
Okay.
And I'm going to read it here, and then I just want you to make some comments on this, okay? We therefore call for the creation of a national network of proactive health AI ethics centers that would develop foundational methods, create and maintain living guidelines, coordinate the development, testing, and evaluation of implementation strategies far beyond the institutional review boards, monitor ethics implementations as it evolves, and identify and share best practices. It's a chunky call to action.
It's a mouthful.
But I get it. I get it, right? But I'm reading it, so it's easier for me to take in. So can you give us a little bit more on that?
Well, that's why we emphasize implementation, because I think that this is not going to be easy, and it's going to require a whole new set of organizations, or if not organizations in our traditional sense, but entities that would come together, maybe virtually, probably on a regional basis, and have a real-time oversight that allows regulators, because healthcare is a highly regulated and appropriately so enterprise, to know what's going on and to make sure that certain guardrails are being followed. But as importantly, just what you asked at the very beginning, how do I, as a technology innovator, know which models are good? And
right.
So we need the underwriter's laboratory version of this that would come in. That comes out of NIST, the National Institute of Standards and Technology. So there are models for how we could do this. But it's so much more complex than the size of the plug you put in the wall or something, and changing all the time.
Yes.
So the combination and has all these human factors that, particularly in the healthcare world, but elsewhere as well. But I think we need specific to healthcare because it is a human endeavor and a fundamentally moral endeavor, that we really need to move quickly to have something in place to do this. Now, the other thing is that it's not only setting the standards; it's then having that feedback loop.
Yes,
and that's going to be as important as anything else.
Hey, Chris, did I do a good job with this interview?
Yes.
Feedback loop.
Yeah, clearly you read the article very carefully.
Well, I have to, because I care about this. And the one piece of flavor that I always see in here that always comes from you, proactive rather than reactive.
Yes.
I know that's so much of your character that was put here in the article. And honestly, you should have just emboldened that right here. I know it's a little bit towards the end.
Yeah. Well, so much of our regulations in healthcare have been reactive. Something like the Belmont Report, something terrible happens, and then we put some rule in place, to keep that from happening again. I think we have to really be, in this arena, be much more proactive.
No, this is fantastic. And now that this is out here in the New England Journal of Medicine, what's next for you? What's your next step? What are you working on, and where can people find out more about your research, right, as a physician and also IDSM?
Well, we're both on the faculty at UCSF, and so you can go to UCSF, and there are multiple different websites. Dr. Sim, Ida, is much more involved in the institutional structures and positions. I'm, as a senior physician there, I'm a professor of medicine, and I do a lot of advising of these different entities that are trying to make key decisions for the UCSF system and for the University of California about how do we implement AI in all of these arenas. So my role there is more as an advisor. And I think, people should just follow the literature, follow what they can see at UCSF about AI policy.
Great.
Yeah.
That's great. So I will make sure that this is linked for people to, go back and actually read this.
Sure.
And be able to share it online. Congratulations on having this in the New England Journal of Medicine. It's a massive accomplishment. And I also want to say thank you for coming on the show and taking the time to explain it.
Well, thanks for having me. This has been a fun conversation.
Yeah. Is there anything I missed? Anything you want to close on?
No, I wanted to make sure to get that part in about the shift from having the principles apply only to patients to now having them apply to clinicians.
Yeah, it's a nice balance.
That's a nice balance. And, I would just say in this world that we're so polarized and so much divisiveness that if you go into any hospital in Santa Fe here, there's a sign at the front desk that is the code of conduct for patients.
Yeah.
That, treat people respectfully, treat your nurse with dignity. I mean, we've always trained the nurses to treat the patients with dignity, but we're now at a place where there's so much anger and so much polarization. So I'm hoping that thinking about the principles this way can help to bridge that divide too.
I think that's fantastic. Well, ladies and gentlemen, you just heard Dr. Christine Cassel, and justice is served. Thanks, Chris. Appreciate it.